So all along we've been talking about the organisms getting the right portal of entry, attaching to the host, evading host defenses, and causing damage and disease. But when I left off at the last one, I said the microbes aren't the only ones that can cause damage and disease. You can also have what's called an injurious host response. What that is we overreact or react inappropriately to an infection, and that overreaction or inappropriate reaction can cause damage as well. So my best example for this is Streptococcus pneumoniae. Strep pneumo, here it is. This is the plate that I struck out. Notice it's got this real darkening of the blood, and it's got this very thick bulbous colony appearance. That's mucoid. That's because it produces that capsule, right? And that capsule is one of its best virulence factors. But the thing is, if white blood cells can't phagocytize an organism, well, when they're undergoing phagocytosis, what they do is they send out chemicals called chemokines, and these chemokines are how white blood cells know to come to the area. So if there's a mast cell, say, in the area of this streptococcus, it's going to send out the chemokines so that the phagocytes know to come here. This is the site of the foreign organism. And during phagocytosis, the white blood cells do the same thing. They're sending out more chemokines. But if the organism can't, or if the white blood cell can't degrade Streptococcus pneumoniae, it's going to keep trying, and it's going to keep sending out these chemokines. So it's going to keep recruiting for backup. Come in, I need more help, I need more help. And all of these white blood cells need to come in on some sort of fluid, right? And what does that fluid do then? It ends up pooling in the lungs, and that is what pneumonia is, right? So pneumonia as a result, it's the pooling of fluid in the lungs, and this is the way that Streptococcus causes pneumonia. But it's an excessive host response, because if we would just degrade them in the first place or not send out more chemokines, we wouldn't have this continuous influx of fluid. Alright, so I left off after talking about a bunch of stuff, but you're looking at this red blood cell plate, right? What is the best name for the type of toxin that's depicted here? That's right, it's hemolysin, and you do need to know that, right? That's hemolysin. It's an exotoxin, right? Because it's secreted. And I gave that one away. It's an exotoxin, it's secreted. And what would be the best descriptor for this type of hemolysis? Alpha, beta, or gamma? That's alpha hemolysis. Alpha hemolysis is the incomplete one. It's usually very green or bruised looking. Beta is the one that's complete hemolysis with the golden halo, and gamma hemolytic is non-hemolytic. All right, so far along, we've been looking at the process of infection and disease, okay? The process of infection and disease. We have portal of entry, attachment, surviving host defenses, damage, and disease. But if we look at our patient and we look at just their signs and symptoms, right? The intensity of their symptoms, that is the stages of infection. And so you have the initial exposure, right? So that would be like the portal of entry. And then there would be an incubation period. This is when the organisms are attaching, right? The incubation is that attachment. And then we get into the prodromal stage. That prodromal stage, that's the stage where you say, I start feeling a little peaked. Like I think I'm getting sick is what we almost all say, right? Like I think I'm getting sick. That's the prodromal. That's when, and the reason that we think we're getting sick and we start to feel it is because that's when our host defenses are responding to the presence of the organism. And so we are now surmounting a little bit more of a response. And so our body's a little tired. We're starting to feel it. And then we get to the height of infection, which is the period of invasion. This is when they're causing damage and disease. This is when they are colonizing sterile tissues and causing damage and disease. And that's the point where you know you're infected, right? Like, don't come near me, I'm sick, or you scoot away from your lab partner because you know full well they're infected too. And then eventually, we have the convalescence period. Convalescence is the recovery. That's the part where now, hopefully, right, the scales get tipped back in the host favor, and now our defenses start to remove the microorganism, start to form memory so they can never come back, and their numbers deplete, and the intensity of our symptoms deplete. So my question to you is, during the incubation period, are you contagious? Could you get that infection from somebody else, or could they get it from you? They could, right? You just got it, so there's no reason. How about prodromal? How about I think I'm getting sick? Tell me how many times you've been sitting in lab and the person next to you is like, I think I'm getting sick. And you're like, scoot, 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 don't talk to me. Like, of course, right? You're infectious there. You're contagious there. How about the height of infection? For sure, right? Oh my gosh, wash your hands, cover your nose, like sneeze into your elbows, please. Like, do not come near me. You are so contagious. What about convalescence? This one I usually get mixed answers from students. Okay, so think about, we often think about bacterial or viral infections during this process, but think about a helminth infection, right? You're getting better, but you're still pooping eggs and larvae, right? You're just pooping fewer of them. Are you still infectious? That's right. So you are infectious at all stages during this process. Yeah, just depends on the organism. All right. So I mentioned back here signs and symptoms, but let's be clear. A sign is something that you can read or see or measure, right? So it's an objective thing by an observer, whereas a symptom is only subjective by a patient. So, for example, a sign would be a pustule. I don't know. That would be a sign, whereas a headache would be a symptom. What do you think about coughing? That would be a sign, right? Swollen, that would be a sign, right? You might feel a sign. That might be both. How about fever? Yes, fever would be both for sure, right? Because somebody could measure a fever, but you definitely feel a fever, right? We're actually going to get into inflammation in the next topic. And inflammation is characterized by the 3 cardinal signs, they call them: rubor, calor, tumor, and dolor. Rubor is redness, rubor, like rubies. Calor, like calories, is heat. Tumor is swelling. And dolor, what do you think dolor is? Pain. Dolor is pain. And so the collection is called the syndrome. So these are just definitions. You should just know these terms so that you're using them appropriately. And you should remember that there are sometimes people who are asymptomatic, so they don't show signs or symptoms, or they may be subclinical. Like, they may have them, but they're not measurable. All right, so we're almost done, right? Now we need to do what? What does that organism need to do to continue its life cycle? It needs to find a new host, right? So it's got to get out. It's got to leave by the portal of exit. These are usually secretions, excretions, discharge, or sloughed tissue. These are my favorites. Think about covering your nose when you sneeze or cough, because that can leave your body at something like 600 miles an hour, and it just aerosolizes, right? So definitely one of our types of portals of entry, but you could also have exudate from lesions. Sometimes just direct sloughing of the epithelial cells can pass along some viruses that are in those cells. Feces, we know, is definitely a portal of exit. And then sex can be a portal of exit. And from mother to fetus could be considered a portal of exit. So basically all the ones that were portal of exits or entries are now portal of exit. We do need to think about blood, though. In the world of what we call universal precautions, universal precautions means that you treat everything as if it was infectious. And that may seem kind of normal for you, which is good, because you're at that generation where universal precautions have been in place. But for the longest time, people didn't realize that you needed to treat blood as if it was potentially infectious, because they didn't realize that the microbes could be in the blood. And so blood can be a portal of exit. And what would be some of our universal precautions that we would use? Gloves, masks, washing, right? Scrubs. Oh my gosh, don't get me started on the people that I see out in public wearing scrubs when that's the whole point, is to scrub them or wash them and leave them behind with the microbes on them, right? That's all part of our aseptic techniques and our universal precautions. Masks would be another one if you're going to be a hygienist, right? Glasses for aerosols, because your mucous membrane of your eye can get things. So these are all really important things, right? Especially if you're going to be in healthcare. But even if you're thinking about changing the kitty litter box, well, we know now that there's microbes everywhere. Okay, few more things though. Some organisms don't always leave the portal of exit. That would be called a chronic or latent infection, depending on the type of microbe. Things like herpes, right? Herpes comes and goes. Hepatitis never really leaves. AIDS, Epstein-Barr. Anybody know what Epstein-Barr causes? Mono. So that never really leaves. You always have mono once you've had it. Typhoid fever, tuberculosis, malaria. We're even learning that West Nile might be a chronic infection. People who even survived West Nile now seem to be having kidney problems. So, and then there's also a person who can be infected but may not be shedding, or they may be shedding, but they're constantly infected, and that's called a carrier. And we're going to learn about different types of carriers, but one type can be an infected person. So that's part of passing microbes. All right. Now, if you have a chronic or persistent infection, remember there may be some permanent damage. So that's called sequelae. That's another term. Meningitis, strep throat, Lyme disease, polio, those can all have long-term results. So you may not continue to be infected, but you may have long-lasting effects. So that kind of fits into this slide in this way. All right, I'm going to put a pin in this one too and wrap up with our epidemiology, our last little unit here.